Welcome back. I am absolutely thrilled you're here today because, well, we're going to put on our clinical detective hats. We're looking into pediatric musculoskeletal conditions, and let me tell you, children are not just miniature adults. Their bones are actively growing, their blood supply is totally different, and the way they present with injuries, it requires a very specific, highly analytical mindset. Today, we're going to decode some pretty complex anatomical puzzles, relying solely on the structural evidence we see right in front of us in this explainer.
So let's start with a classic clinical scenario to hook you right in. Picture this. A young boy walks into your clinic. He's got a really noticeable limp, and he's complaining that his knee hurts. Now ask yourself, are we looking at a slow, gradual bone remodeling process here, or is this an acute, highly unstable emergency that needs immediate intervention? As we'll see, that super simple presentation, just a limp and knee pain, could actually send us down two drastically different pathways.
To make sure we solve these puzzles systematically, here's our roadmap for today. Number 1, the hip dilemma. Number 2, the spine spectrum. Number 3, diagnosing structural scoliosis. Number 4, scoliosis surgical management. And finally, number 5, assessing pediatric fractures.
All right, Section 1, the hip dilemma. 2 suspects. Let's dive right into this first puzzle. Our very first suspect is Legg-Calve Perthes disease. I know, the name sounds incredibly intimidating, but if we just break down the pathophysiology, it makes perfect sense. Basically, this condition involves impaired blood circulation to the femoral head, the ball of the hip joint. When that blood flow gets cut off, the bone tissue actually dies. We call this aseptic necrosis. Aseptic just meaning it's not caused by an infection. And this perfectly illustrates the long, really slow nature of this disease, which unfolds in 4 distinct stages. First, you have necrosis, where the bone tissue begins to die off. Second is fragmentation, where that weakened bone starts breaking down. Third is reossification, as new bone slowly begins to form. And finally, remodeling, where the femoral head reshapes itself. This whole shebang is insidious. It's a gradual story of bone death and reshaping that requires long-term activity restriction just to prevent the hip from healing in a deformed shape.
Now to really sharpen our detective skills, let's contrast that with our second suspect, slipped capital femoral epiphysis, or SCFE for short. While Legg-Calve Perthes is gradual and often shows up early on as an intermittent painless limp, SCFE is the exact opposite. SCFE involves an acute, sudden displacement at the hip joint. A child with SCFE is often going to have an externally rotated leg, a pronounced limp, and severe pain. And hey, here's a fantastic diagnostic pearl for you. Both of these conditions can present with knee pain. But why? Well, it's because the hip and the knee actually share overlapping sensory nerve pathways. So pain that originates in the hip is referred down to the knee. As a clinical detective, you simply can't let yourself be distracted by the knee when the real culprit is hiding up in the hip.
And guys, this brings us to a huge, absolutely critical red flag situation regarding how we respond to a potential SCFE. If you even suspect a child has SCFE, they must become immediately non-weight bearing. And absolutely under no circumstances do you do any range of motion exercises. Just think about the mechanics here for a second. You've got an unstable epiphyseal displacement. Essentially, the ball of the hip is literally slipping off the bone. If you force movement or let the kid walk on it, you risk making that displacement so much worse before a surgeon can get in there and stabilize it. You are literally freezing the scene of the crime to protect your patient.
Okay, Section 2, the spine spectrum, categorizing curves. We've cracked the hip dilemma, so let's travel on up the skeletal system to our next major anatomical region.
Before we narrow our focus too much, we really need to correctly categorize the variations of spinal curvature. First up, lordosis. This is an exaggerated inward curvature, usually down in the lumbar or sometimes cervical region, giving this sort of sway-back appearance. Next is kyphosis. That's an excessive outward curvature in the thoracic region. It creates a forward rounded or hunched look. And finally, scoliosis, which is a lateral or sideways curve that crucially also involves spinal rotation. So just to recap, lordosis is swayback, kyphosis is hunched, and scoliosis is sideways with rotation.
Section 3, diagnosing structural scoliosis, screening strategies. Now that we've got our baseline definitions locked in, let's zoom in on structural scoliosis, which is the most common idiopathic form, and see how we actually catch it.
First things first, structural scoliosis isn't caused by slouching at a desk or carrying a ridiculously heavy backpack. It actually has a genetic tendency, and it typically rears its head during rapid growth spurts. That's exactly why the timing of screening is so critical. We are looking for this during pre-adolescence, usually right around ages 10 to 15. The screening process itself is incredibly specific. You need to observe the child in just their underwear so you can get a perfectly clear view of the spine and the hips. But the absolute gold standard here? That's the forward bend test. The child just bends forward at the waist, letting their arms hang straight down. And what are we hunting for? Rib or flank asymmetry. Because the spine rotates as it curves sideways, it literally pushes the ribs up on one side. If we spot that asymmetry, we immediately measure the angle of trunk rotation with a neat little specialized tool called a scoliometer.
Okay, so you've identified a curve. What next? Well, we turn straight to radiography to answer two massive questions. Question number one, how severe is this curve right now? We figure that out by measuring the Calve angle on an X-ray. Question number two, how much more is this child going to grow? Because think about it, if they're still actively growing, that curve has a really high risk of getting much worse. We estimate their remaining growth potential using the Risser scale, which looks at skeletal maturity. Combining the Calve angle and the Risser scale gives the healthcare team the exact, precise blueprint they need to plan the best treatment.
Section 4, Scoliosis Surgical Management, Treatment Pathways. And that blueprint brings us directly into our next focus.
Treatment depends heavily on those exact measurements we just talked about. The two main interventions for a progressing curve are bracing and surgical spinal fusion. Now, a quick heads up here. What's fascinating is that the thresholds for these treatments can overlap slightly. Bracing is generally used for growing children with curves sitting between 25 and 45 degrees. And listen, the goal of a brace is not to magically cure the curve overnight. The goal is to hold the spine securely in place and prevent it from progressing while the child finishes growing. But it's tough. They have to wear it 16 to 23 hours a day. On the flip side, surgery, specifically spinal fusion with rod placement, is generally reserved for severe curves, typically cited as anything greater than 40 degrees. Now, I want to be super explicit about this. Different medical sources will sometimes give you slightly different degree cutoffs. These numbers are fantastic teaching guidelines, but they aren't rigid universal laws. The real-world decision always comes down to the exact location of the curve, the child's remaining growth, and the provider's expert evaluation.
If surgery is the chosen path, the preparation is seriously intense. Spinal instrumentation is a major procedure. Preoperatively, we aren't just checking off boxes on a chart, we are heavily preparing the adolescent and their family. Because there's a risk of significant blood loss, we actually discuss autologous, meaning self-donated, blood donation well ahead of time. We also orient them to the Pediatric Intensive Care Unit, the PICU, because that is exactly where they'll be waking up. We have to mentally prepare them for the heavy machinery they're going to be attached to, a patient-controlled analgesia or PCA pump for their pain, an NG tube, possibly a chest tube, and an indwelling urinary catheter. Oh, and we also make sure to let them know to expect decreased motor and sensory function in their legs right after surgery. We are setting those expectations early so they aren't completely terrified when they first wake up.
Once they're out of surgery and settled in the PICU, the detective work continues around the clock. Pain is managed heavily with that PCA pump, but the single most crucial point here is protecting that brand new spinal fusion. We absolutely have to maintain spinal alignment, and we do that using strict log rolling to turn the patient, making absolutely sure the spine doesn't twist even a little bit. We're also rigorously performing frequent neurovascular checks. Any unexpected weakness, any loss of sensation or altered movement in the legs is an immediate, glaring red flag for a potential spinal cord injury. Plus, we're constantly listening to their abdomen, assessing bowel sounds to monitor for a paralytic ileus, which is a scary condition where the intestines essentially just freeze up after the immense trauma of surgery. It is a highly demanding, high-stakes recovery process.
All right, final stretch. Section 5, Assessing Pediatric Fractures, Infant Assessment. Let's pivot away from adolescents for a second and go back to infants, focusing on a really critical safety check. Imagine you're looking at a radiograph of a tiny infant, and you clearly see evidence of multiple previous fractures, all in various stages of healing. This is, without a doubt, one of the most challenging differential diagnoses a clinical detective will ever face. On one hand, this presentation could be the result of physical maltreatment, which is a horrific reality that we absolutely must always screen for. However, it can also be the result of osteogenesis imperfecta, or OI. That's a genetic bone disorder that basically causes bones to break incredibly easily. To tell the difference, you've got to look for the classic OI clues: a distinct blue tint to the sclera, the whites of the eyes, early hearing loss, and dental involvement, like unusually brittle teeth. If it turns out to be OI, the infant requires extreme, and I mean extreme, gentle handling precautions just to prevent further breaks during totally routine care. They also might be treated with bisphosphonate therapy to help strengthen those fragile bones. You have to carefully, methodically weigh this objective evidence. You absolutely cannot jump to premature conclusions, because falsely accusing a family is devastating, but missing actual abuse is equally tragic. You have to follow the clinical evidence, step by step.
And that brings us to our final, ultimate question for this explainer. Whether you're distinguishing a gradual hip necrosis from an acute epiphyseal slip, whether you're precisely measuring the angle of a spinal rotation, or carefully reviewing an infant's x-ray, the question always remains. As a clinical detective, are you going to leap to assumptions, or will you follow the evidence step by step to protect your patient? Thank you so much for joining me today to decode these pediatric musculoskeletal conditions. Keep questioning everything, keep learning, and I'll catch you on the next explainer.